scapula. So you know the terms. Before discussing any joint, you should know the bones which are taking part in the formation of the joint. Shoulder joint, you know, shoulder joint is formed by head of the humerus and glenoid cavity of the scapula. So you may also call it glenohumeral joint. Shoulder joint is formed by head of the humerus and glenoid cavity of the scapula. What type of joint it is? It is a synovial joint. What is the subtype? Ball and socket. So it is a synovial joint, ball and socket type. If we consider the axis of movement, it is polyaxial joint. At this joint you can abduct, adduct, flexed, extends, external rotation, internal rotation, and circumduction. Circumduction means this movement in succession. Suppose this is the flexion, abduction, this is flexion, flexion, abduction, this is abduction. Abduction means anterolaterally. Anterolaterally, if we move the way, that is abduction. Anterolaterally. And flexion is movements forwards and medially. Forwards, this is the flexion. And thus, ulto, opposite hoche extension. Forwards and medially, backwards and laterally. Abduction, এটা হচ্ছে তোর ফরওয়ার্ড অ্যান্ড ল্যাটারালি, অ্যান্ড এটা হচ্ছে ব্যাকওয়ার্ডস অ্যান্ড মিডিয়ালি. দিস ইজ দ্য অ্যাডাকশন. When I am doing like this, this is a circumduction. In succession, all these movements in succession, if we do, that is abduction, circumduction. So it is a polyaxial joint. Now, you should know that the glenoid cavity is very shallow, and it only and globular head. The head of the humerus is actually, it is 1/3 of a sphere. Actually, head of the humerus 1/3 of a sphere, and head 4 times greater than the glenoid cavity. 4 times greater than the glenoid cavity, and glenoid cavity is very shallow. So this joint is very unstable, very unstable joint. The capsule which actually covers this joint is lax. So all these factors actually favoring the instability of the joint. Number 1, shallow glenoid cavity. Number 2, the articulating head, it is 4 times greater than the glenoid cavity. Capsule around the joint lax. So all these factors actually favors the instability of the joint. But this instability actually, it is because of the high mobility of the joint. তাহলে mobility at the expense of stability. Here mobility is at the expense of stability. স্ট্যাবিলিটিকে যেমন তো স্যাক্রিফাইস করেছি, সেই জন্য মোবিলিটি বেড়ে গেছে. মোবিলিটি যদি বেশি হতো তাহলে স্টেবিলিটিটা কম হতো. যদি মানে মোবিলিটিটা কম হতো, স্টেবিলিটি বেশি হলে মোবিলিটি কম হতো. অ্যাজ ফর এক্সাম্পল, দ্যাট ইজ হিপ জয়েন্ট. হিপ জয়েন্ট ইজ মোর স্টেবল দ্যান দ্য shoulder joint. Now, after describing the articulating bones, you should know the ligaments. You know the ligaments actually connects and holds the joint. The first ligaments which you will describe is capsular ligament. Capsular ligament. capsular ligament, you have to describe the attachment of the capsular ligament. Capsular ligaments, if we consider the glenoidal aspect, it is attached to the margin of the glenoid cavity. It is attached to the margin of the glenoid cavity. But here you should specify this attachment actually includes supraglenoid tubercle. There is a supraglenoid tubercle. You can remember, mone porche? That supraglenoid tubercle will be within the capsule. So this capsular attachment will include the supraglenoid tubercle, but it will exclude the infraglenoid tubercle. So from the infraglenoid tubercle, triceps, long head of triceps originates. So triceps is extracapsular, but long head of the biceps is intracapsular, right? There is a rim of fibrocartilage. There is a rim of fibrocartilage that is called labrum, glenoidal labrum. This glenoidal labrum lies within the capsule. তাহলে হয়ে গেল ক্যাপসুলার লিগামেন্টের অ্যাটাচমেন্ট টুয়ার্ডস দ্য glenoid cavity. Now towards the humerus. It is attached to the neck of the humerus. There are three necks. Humerus has got three necks: anatomical neck, surgical neck and morphological neck. So it is attached to the anatomical neck. So on that aspect it is attached to the anatomical neck. Here you should specify some point. Above there is a gap. Through this gap, long tendon of the biceps long tendon escapes through this gap. As you know, the biceps tendon is intracapsular, so it is within the capsule. Now it has to come out from the capsule, so there must be a gap in the capsule. On the medial aspect, the capsule actually extends up to the surgical neck. So here capsule is more lax, and at the medial aspect, the attachment of the long head of the triceps, that is separated by, long head of the triceps is separated by axillary nerve. So inferior medial aspect of the capsule is very weak. So what will happen? What may happen? Because of this weakness, the maximum shoulder dislocation occurs inferiorly. So inferior dislocation is more common because inferiorly the capsule recedes more towards the surgical neck. It is not actually follow the anatomical neck, and their muscle support is also less. So this is the weakness of the capsule. Now the capsule is thickened anteriorly in three bands. This capsule is thickened anteriorly, and that thickening is best visualized if it is looked from within the capsule. ক্যাপসুলের যদি ভিতর থেকে দেখা যেত ব্যান্ডগুলো বোঝা যায়। সো ইট ইজ বেটার ডিফাইন ফ্রম উইদিন, মানে যদি যখন ক্যাপসুলটা কেটে ওপেন করবি যখন ভালো বোঝা যাবে আর কি। এমনি মনে রাখ যে অ্যান্টিরিয়রলি দ্য ক্যাপসুল ইজ থিকেন্ড ইনটু থ্রি ব্যান্ডস। এটার নাম হচ্ছে গ্লিনোহিউমেরাল লিগামেন্ট। Glenohumeral ligament. There are three bands: superior, middle, and inferior band. Between the superior and middle band, the part of the capsule is weak. Between the superior and middle, anteriorly the capsule is weak. So anterior dislocation generally occurs through this weak spot বা weak site. এই গেল তোর ক্যাপসুল। নাও another ligament that is called coracohumeral ligament. Coracohumeral ligament, there is another ligament. Coracohumeral ligament as its name specifies, from root of the coracoid process up to the neck of the humerus, near the greater tuberosity. Greater tuberosity কাছে এখান থেকে থাকে আর কি. This is the coracohumeral ligament, right? Another ligament is transhumeral ligament. Transhumeral ligament between the greater tuberosity and lesser tuberosity. And you know there is a groove known as bicipital groove, and through this bicipital groove passes the long head of the biceps. So this ligament actually prevents the displacement of this biceps, long head of the biceps ligament. Transverse humeral ligament. So these are the ligaments. তাহলে কি ligaments হলো? Capsular ligament. Number 2, capsular ligament again thickened to form glenohumeral ligament. 3 bands: superior, intermediate, superior, middle, and inferior are acromial-humeral ligament and transverse humeral ligament. There is another ligament that is called. It extends from acromion process to the coracoid process, the thoracoacromial ligament. Acromial and coracoacromial, not thoraco, coracoacromial. Coracoid process to acromial. They actually prevent the upward displacement of the joint. Coracoacromial ligament. And between this ligament and the below this ligament there is a bursa. This bursa, when there will be bursa, the function of the bursa actually it prevents the friction. So if we come from above downwards, first this bursa, ligament, coracoacromial ligament, then bursa, then supraspinatus muscle. In this, it is the superior relation of the joint. Sometimes you have to describe the relation of the joint. The superior relation of the joint, when I will describe from above downwards, most above, this is the deltoid muscle, middle fiber deltoid muscle. Then I will get this ligament, coracoacromial ligament, then subacromial bursa, then supraspinatus tendon. ডিসকাশন মানে কিছুটা আর তোর মানে হেফাজত হয়ে যাচ্ছে আর কি, মানে পরপর মানে এগুলো বলতে হবে আর কি, মানে একটা বলতে যে আর একটাতে চলে যাচ্ছে আর কি. তো রিলেশন বলুন, আবার এগুলো বলতে হবে রিলেশনসের. তাহলে লিগামেন্টস হলো, হ্যাঁ, নাও লিগামেন্টসের পর হয়. এবার লিগামেন্টসের পরে এবার রিলেশনস. তাহলে রিলেশন এবার পড়ি. রিলেশনস, superior relations I have completed. Anterior relation. Anteriorly, what lies anteriorly? This deltoid muscle it is present anteriorly, laterally, and posteriorly. It has a big attachment, wide attachment. So anterior fibers of the deltoid. Then you will get what muscle you will get here? And the muscles which is attached to the coracoid process. What muscle attached to the coracoid process? 2 muscles attached to the coracoid process: short head of biceps and coracobrachialis. So that will come anterior relation. First, anterior fibers of the deltoid, then coracoid process and muscle attached to it. That is short head of biceps and coracobrachialis. Anterior relation. Posterior relation, posterior fibers of the deltoid and infraspinatus and teres minor posterior, right? তাহলে anterior, posterior, superior relations complete. Now come to the what are the factors that provide stability to the joint? What factors provide stability to the joint? What?
Synovial fluid.
Synovial fluid to mobility joint, stability. I am talking about not mobility but stability. Rotator cuff muscle. Have you heard the name of rotator cuff muscles? Rotator cuff muscles. The rotator cuff muscles, you may be asked in the exam, there are 4 muscles. Anteriorly, it is the subscapularis muscles, subscapularis muscle. Posteriorly, infraspinatus and teres minor posteriorly, and superiorly supraspinatus. These muscles, the tendon of these muscles actually blends with the capsule of the shoulder joint. They provide stability. If they become inflamed, if this tendon become inflamed, then this condition is known as tendinitis. If there is tendinitis, then you will feel pain during abduction of the shoulder joint. That is called frozen shoulder. The frozen shoulder is a condition where there is tendinitis of these muscles which form the rotator cuff around the joint. Right? So these are the rotator cuff muscles. It imparts, by it gives stability to the joint, and muscles around also gives stability to the joint. Atmospheric pressure also helps in the stability of the joint, and all the tendons which I described, they also provide stability to the joints. Right? Now you should know the movement of the joints. Movement of the joints, nerve supply of the joints, arterial supply of the joints. So under all these headings, if one joint comes in the exam, under all these headings you should describe. First of all, type of the joint. Number 2, ligaments of the joints. Number 3, muscles around the joint. Number 4, blood supply, nerve supply of the joint. Number 7, movement of the joints. Movement of the joints. Right? Now before describing movements, you should know the axis of the movement or plane of the movement. Now when I am flexing, flexion and extension, what is the plane of the joints along which plane this movement is taking place? Along which plane it is I am moving the joint? It is along the plane of the glenoid cavity. Glenoid cavity plane, actually we are moving this according to this plane. Flexion, extension, it is occurring along the plane of the glenoid cavity. And abduction, adduction. Abduction, adduction is actually occurring along the plane of the scapula, scapular body. Scapula, how to hold scapula in anatomical position. Anatomical position, how to hold scapula. Scapula का काज आसे रे? नहीं. How to hold scapula. Scapular glenoid labrum, it will directed towards lateral, ऐसे ना anterior posteriorly. बोलचे, if we hold the scapula, suppose this is the scapular glenoid labrum. The glenoid labrum, I will hold it to anterior posteriorly or laterally. When you hold the scapula, the glenoid labrum will look laterally. Actually it will be placed between this plane is known as sagittal plane and this plane is known as coronal plane. In between two planes like this, you have to hold the scapula in anatomical position along the in the angle between the sagittal plane and coronal plane এরকম ভাবে ধরতে হবে, মানে সে রিভলভ ধরা করে এরকম উঁচু করে, বুঝতে পারলি? দিস ইজ দ্য পজিশন অফ দ্য, তাহলে এই পজিশন যদি রাখিস তাহলে এর যে প্লেন, দ্য প্লেন অফ দ্য ব্লেড অফ দ্য স্ক্যাপুলা, দিস অ্যাবডাকশন অ্যাডাকশন মুভমেন্ট ইজ occurring along the plane of the body of the scapula. Slowly. Now, abduction, adduction, external rotation, and internal rotation. If you want to externally rotate, first we will flex the arm, elbow. Then you will laterally. This is lateral rotation, and this is the medial rotation. Right. Now, most important movement is the abduction movement. Abduction movement of the shoulder joint is most important. Now, what muscles causes abduction of the shoulder joint? Number one, this is the superior band of the glenohumeral ligament, intermediate band and lower band of the glenohumeral ligament. So, what is glenohumeral ligament? It is actually capsular ligament. Anteriorly, it has become thickened. This thickened portion is known as glenohumeral ligament. Three bands: superior, middle, and inferior band. Out of this, between superior and middle band, this part is weak. Actually, this part of the intervening part is covered by capsule, and this capsule has been thickened in this part. So this part of the capsule is weak. The anteriorly weak spot is between the superior and middle glenohumeral ligament. Through this weak spot, sometimes this joint may dislocate. That is called anterior dislocation. Now, this is the another ligament which is bridging the bicipital groove. This is called transverse humeral ligament. Through this ligament actually passing long head of the biceps. So, long head of the biceps will not be displaced during the movement of the shoulder joint. This is the acromial process. This is the coracoid process. Another ligament from the root of the coracoid process extends from here up to the greater tuberosity. Near the neck, anatomical neck, this is called coracohumeral ligament. তাহলে টোটাল লিগামেন্ট কটা হলো? ক্যাপসুলার লিগামেন্ট, and capsular ligament is these parts, superior and middle inferior band of the glenohumeral ligament, then coracohumeral ligament, transverse humeral ligament, right? And this joint, man, glenoid cavity has become deepened by a ring of fibrocartilage that is called labrum, glenoidal labrum. So these are the ligaments of the joints. Now come to the after ligaments. Now we'll discuss the bursa. What are the bursa related to this joint? Number one bursa, I am drawing this here. Another, I am drawing the glenoid cavity. This is anterior aspect, this is posterior aspect. It is superior, it is inferior. Supraspinatus. infraspinatus. Teres minor. Subscapularis. Subscapularis. These are the tendon of the muscles. This is the infraspinatus. This is the teres minor. This is subscapularis, the supraspinatus. These are the tendon near the joint. They are formed rotator cuff. Rotator cuff. Now above this there is a ligament that is known as, here is, suppose this is coracoid process. This is acromion process. This ligament known as coracoacromial ligament. Coracoacromial ligament. Just below this coracoacromial ligament, there is a bursa. There is a bursa. The name of this bursa is, as it is below the acromial process, subacromial bursa. So subacromial bursa. Subacromial bursa. Subacromial bursa. So bursa related to this joint, there are several bursa which is related to the joint. Number one, subacromial bursa. What are the other? Number one, subacromial. Number two, subscapular bursa. Subscapular bursa. Subscapular bursa. Subscapular bursa, so it must be deep to subscapularis muscle. Subscapular bursa. Thin. Infraspinatus bursa. Infraspinatus bursa. Infraspinatus bursa. It is deep to the infraspinatus muscle. Subscapular bursa actually communicate with the joint cavity, and infraspinatus bursa sometimes may communicate with the joint cavity. Now, after describing the capsule, when you will describe the capsule of a joint, and you know the capsule of the joint actually synovial membrane. Synovial membrane actually lines the inside of the capsule. This synovial membrane, here you know there is a tendon that lies within the shoulder joint. What is the name of this tendon? One tendon lies within the capsule. What is the name of that tendon? Tendon of one muscle takes origin within the capsule. Supraglenoid tubercle কি মাসল অ্যারাইজ করে? সুপ্রাগ্লিনোয়েড টিউবারকুল থেকে কোন মাসল অ্যারাইজ করে? বাইসেপস ব্রেকাই। বাইসেপস ব্রেকাই বললাম না, সুপ্রাগ্লিনোয়েড টিউবারকুল থেকে অ্যারাইজ করে। Long head of the biceps. Long head of the biceps takes origin from the supraglenoid tubercle. It is within the capsule. So its ligament will be within the capsule. So that ligament is actually intracapsular but extra synovial. It will be outside the synovial, right? So you should mention that. So these are the bursa and these are the ligaments. Now come to the relations of this joint. I have already told you relations. Here you see superior relations. If you are asked to discuss the superior relation, from this diagram you can identify the superior relation. This is the this ligament, name of this ligament is, this is acromial process, this is coracoacromial ligament, then subacromial bursa, then supraspinatus muscle, and above all this lies the medial fiber, the superior fiber of the deltoid muscle. Now posterior relations. Posterior relations, I have already told you, posteriorly lies infraspinatus muscle and teres minor muscle and posterior fibers of the deltoid. This is the posterior relation. Anterior fiber of the muscle and the coracoid process and the muscles arising from the coracoid process, that is short head of the biceps and coracobrachialis. So these are the anterior relations. Below lies from the infraglenoid tubercle, what arises? Long head of the triceps. So long head of the triceps inferiorly, and between the long head of the triceps and the capsule lies one nerve, important nerve, that is axillary nerve. So axillary nerve and posterior circumflex humeral artery. So these are the inferior relations. So these are the relations of the shoulder joint. Now come to the nerve supply. What is the nerve supply of this joint? Nerve supply, number one nerve is axillary nerve. It lies along the surgical neck of the humerus, so it supplies this joint. And another nerve, that is the musculocutaneous nerve. Musculocutaneous nerve, you know, it supplies all the muscles of the arm, so it also gives some tweak to this joint. So musculocutaneous nerve. Another nerve, that is called suprascapular nerve. You have seen the scapular notch in scapula. Through this notch pass one nerve, that is, what is the name of this nerve? Supraspinous nerve. That supraspinous nerve also supplies this joint. There are three nerves. Number one, first nerve, which is axillary nerve, then supraspinous nerve and musculocutaneous nerve. What is the artery supplying this joint? Artery, number one, circumflex humeral artery, anterior circumflex humeral, posterior circumflex humeral, and supraspinous artery আছে ওখানে নার্ভ এন্ড আর্টারি দুটো ছিল, supraspinous artery and subscapular artery. So these are the four arteries that supplies this joint, right? Now come to the relations হয়ে গেল. Now what are the movement of this joint? Movement হচ্ছে flexion, extension, abduction, adduction, external rotation, internal rotation, and আর কি circumduction. After describing the movement, you should action of the which muscle move this joint. Number one, now come to the flexion. Now tell me flexion, the axis or plane of the flexion you have to describe. Flexion is this movement, that is forwards and medially and backwards and laterally. This movement occurring along which plane? That is the plane of the glenoid cavity. Now what are the muscles that are moving this joint? Flexion is done by which muscle? এখানকার কি মাসল আছে? Anterior fibers of the deltoid and clavicular head of the pectoralis major. তাহলে clavicular head of the pectoralis major and anterior fibers of the deltoid, that is producing the flexion. Now extension movement is done by পেছনে কি মাসল আছে? Extension is done by posterior fiber of the deltoid, posterior fiber of the deltoid, and one muscle is coming here, that is called latissimus dorsi. Latissimus dorsi. So posterior head of the deltoid and latissimus dorsi. Right. Now abduction and adduction. Abduction and adduction occurring at along which plane? It is the occurring along the plane of the body of the scapula. Now which muscle is causing adduction? Adduction movement is done by adduction কে রে কোন মাসল টানছে বল, বুঝতে পারছি না একদম। Adduction is done by teres major এখানে লেগে আছে, এখান থেকে এখানে teres major লেগে আছে। তাহলে teres major is coming from where? From the lateral border of the scapula to the humerus. তাহলে এখান থেকে যদি আসে তাহলে টানলে কি হবে? এদিকে আসবে। তাহলে it is adduction is teres major and latissimus dorsi also called adduction, right? And this fiber, main fiber তো এটা, এই যে pectoralis major, এর এই হেডটা কি বলে? This head, this is the sternum, sternocostal head. So it is the adduction. Abduction, first 15-degree abduction, এটা মনে রাখবে, এটা খুব ইম্পর্টেন্ট। First initiation of the abduction, তাহলে first 15-degree abduction is done by supraspinatus. First 15 degree done by supraspinatus. Then 15 degree to 90 to 120 degree. 15 থেকে আবার 120 degree পর্যন্ত it is done by middle fiber of the deltoid. এটাকে আর একটা নাম হচ্ছে acromial fiber of the deltoid, that is from up to 120 degree. Now when I am abducting overhead abduction is done by overhead abduction actually occurring at two joints. Number one shoulder joint and number two shoulder girdle. Shoulder girdle is taking part at overhead abduction. Now overhead abduction is 180 degree. The overhead abduction 120 degree occurring is the shoulder joint and 60 degree is occurring at the shoulder girdle. Shoulder girdle joint কি কি আছে? What are the joints and the shoulder girdle? এটা হচ্ছে acromioclavicular আর এটা sternoclavicular আর acromioclavicular, এই দুটো জয়েন্ট হচ্ছে shoulder girdle joint. acromioclavicular and sternoclavicular. acromioclavicular এই 60 ডিগ্রি যেটা বললাম, 120 ডিগ্রি হচ্ছে এতে শোল্ডারে আর 60 ডিগ্রি হচ্ছে শোল্ডার গার্ডলে। তার মধ্যে 20 ডিগ্রি is occurring at this joint, that is sternoclavicular and this is sternoclavicular. এখানে হচ্ছে তোর 40 ডিগ্রি, এখানে 40 ডিগ্রি, এখানে 20 ডিগ্রি, 60 ডিগ্রি হয়ে গেল। আর 120 ডিগ্রি হয়েছে শোল্ডার জয়েন্টে। বুঝতে পারলি? এটা বুঝতে পেরেছি কিনা আগে দেখ। তাহলে ফার্স্ট ইনিশিয়েশন অফ দ্য মুভমেন্ট হচ্ছে 15 ডিগ্রি বাই সুপ্রাস্পাইনেটাস, দেন মিডল ফাইবার অফ দ্য ডেল্টয়েড আপ টু 120। এবার আমি যখন ওভারহেড শোল্ডার যখন 180 ডিগ্রিতে যাচ্ছি, দেন দিস মুভমেন্ট ইজ অকারিং at shoulder girdle, at shoulder joint as well as shoulder girdle. Shoulder, if it is 180 degree, 120 degree is occurring at the shoulder joint and 60 degree is occurring at the shoulder girdle. Etu bolbi. Right? And shoulder girdle movement ke korache. Which muscle is moving the shoulder girdle? Means which muscle is pushing the scapula forwards. That is the movement of the shoulder girdle. Now, which muscle is moving the shoulder girdle? Which muscle? Number one muscle hoche trapezius. And trapezius, lower and upper দুটো fiber আছে. Lower and upper fiber of trapezius as well as main muscle হচ্ছে তোর serratus anterior. তাহলে trapezius aided by serratus anterior. These two muscles actually moving the shoulder girdle. এটা মনে রাখবি shoulder girdle. So these are the abduction movement. শুধু abduction movement ই short note আসতে পারে. Abduction movement of the shoulder joint. Then you have to describe all these things. ভালো করে বুঝেন আগে। Shoulder girdle initiation by supraspinatus, then that is the 15 degree movement. এই এতটুকু ধর। Then 120 degree up to 120 degree middle fiber of the deltoid, and above when I be above overhead abduction, then movement is not occurring only on the shoulder joint, but it is also occurring in the shoulder girdle. And shoulder girdle actually is moved by important muscles, trapezius as well as serratus anterior. Serratus anterior, if paralyzed, what will happen? Winging of scapula. Serratus muscle is also known as boxer's muscles, but swimmer's muscles. How will you know that serratus anterior is paralyzed? If you ask to push the wall, the medial border of the scapula will stand out. By this you can understand that this serratus anterior is paralyzed. Which nerve actually supplies this? Long thoracic nerve of Bell. In this way you will be asked questions. So এই গেল তোর movement of the abduction movement. Abduction, adduction, flexion, extension সব হয়ে গেল, circumduction. Now lateral rotation. Which muscle cause lateral rotation? Lateral rotation পিছে যে মাসল আছে, that is infraspinatus and teres minor, and posterior fibers of the deltoid may sometimes fail, and medial rotation is done by the subscapularis. So these are the movements. তাহলে নার্ভ সাপ্লাই বলে দিয়েছি। There are three nerves. First nerve axillary nerve, second nerve musculocutaneous nerve, third nerve supraspinous nerve. Arterial supply, circumflex-humeral artery, posterior circumhumeral artery is following the axillary artery, so that artery supplying, and anterior circumhumeral artery plus supraspinous artery and subscapular artery, they are supplying the joint. তো নার্ভ সাপ্লাই হয়ে গেল, তারপরে তোর হয়ে গেল কি বলে অ্যাকশন হয়ে গেল, টাইপ সাপ্লাই সব হয়ে গেল, কমপ্লিট। দিস জয়েন্ট ইজ কমপ্লিট। মেডিকেল স্টুডেন্ট, so if anything happens in your locality, you may be called. They will not find that you have been doctor or not. Suppose one patient came to you with shoulder dislocation. Most common shoulder dislocation is inferior dislocation. It is very common dislocation. If this type of patient comes to you, they will first go to the quack. If quack fails, then they will come to you. You are a qualified doctor. Then how will you reduce this dislocation, inferior dislocation? There is some mechanism by which, if you do, you can easily place the joint in position. First of all, what will you do? First of all, patient should lie down in supine position. Supine position. One piece of cloth you will wrap around the shoulder joint. One will hold, and you will flex the elbow and you will pull it downwards. Then what will you do? Then you will actually externally rotate. This arm will be externally rotated, as well as you will adduct the arm like this, and suddenly you will move this forearm like this, adduction. If you do, it will quickly it will be reduced. This is called Caucus maneuver. Caucus, একটা সাহেবের নাম আছে Caucus maneuver. First of all, you will pull, then you will externally rotate, then you will adduct, and then you will move the forearm like this. If you follow this procedure, it will be easily reduced. Before reduction, you should be assured that this patient is not having any fracture. If there is any fracture, and if you do all these things, fracture will increase and pain will increase and you may be beaten. So before that, one X-ray is required. If there, suppose in your locality there is no X-ray, at night this has occurred, so by some exam you will more or less sure that there is no fracture, then you will do this procedure. প্রথমে you will pull, downwards pull. ডাউনওয়ার্ড পুল দিয়ে তো পেশেন্ট তো উইল নিচে নেমে আসবে, সেই জন্য এখানে একটা কাপড় দিয়ে আরেকজন টানবে এদিকে, হ্যাঁ বুঝলি তো, তো একটা কাউন্টার ট্রাকশন, দেন ইউ উইল এক্সটার্নালি রোটেট অ্যান্ড ইউ উইল অ্যাডাক্ট অ্যান্ড দেন দিস, হ্যাঁ ইট উইল ইজিলি রিডিউসড। তাহলে আজকে এটুকু।